Recording.
Welcome in, everyone. Welcome to Tuesdays and Thursdays with CarePatrol. We're so glad you're here today with us, and want to remind you, if you're enjoying being with us on Tuesdays and Thursdays, we'll change our days to Mondays and Fridays moving forward, and that will allow you all 2 opportunities a week, at least, to get CEUs from either us or from Jay Jones, who used to work with us. And of course, there are plenty of other great, educators out there providing great content. Ours are free. If that is helpful to you all, I hope it is. But certainly there's great content that you do need to pay for that others offer. So welcome to Tuesdays and Thursdays with CarePatrol. This month, if those of you who've been with us know that we've been doing ethics topics for the entire month. Today is no different. We're doing medical ethics. And then we'll close the month out. We'll skip Thursday of this week, and we'll close the month out with Dr. Chandler Caldwell doing the ethics of self-care. And so this is very important for social workers, I know, for renewal. So I hope that those of you who are social workers, who have friends who are in social work, who will need this, hour for renewal, that you'll let them know about it on June 28th, which is Tuesday of next week. But for today, again, we're choosing to do medical ethics. And I have to say, you all who've been with us know, and we'll get into some housekeeping now, know that we do an evaluation after the presentation, and that it's password protected, and that inside the evaluation, we ask you for ideas for content. And some folks, don't have ideas, and that's certainly fine, but others do. And some have some pretty, unique ideas. And we've 2 of those today we are going to address as we discuss medical ethics. So very pleased today to be doing, once again, a topic that was suggested by one of our participants here. And so I say this to say to you all who are here with us that we're serious when we say we want to know what you want to know. And we will try every ability to make it possible for you to get those CEs of topics that are important to you. So for today, let's do a little housekeeping. As I mentioned moments ago, we do a survey every evaluation after every hour. And we're accredited by the boards of nursing for the state of Alabama and the board of social work for the state of Alabama. And we have to do a couple of things for them. One is an evaluation. We use SurveyMonkey, and we password protect it. I will let y'all know the password at about 12:45 today or 12:50. And certainly there's always someone who's good to remind me in the chat room. I hope you'll use the chat room. Your mics are muted. We use SurveyMonkey for the evaluation, and I'm going to give that address to y'all. Anyone who's not able to see the screen or the chat room, let me read this to you so that you will have the survey evaluation tool. It's also posted in the chat room if you open that and scroll down. But the address today for today's evaluation is https://www.surveymonkey.com/lowercase r/ all uppercase letters, Z as in zoo, M as in Mary, Y, S as in Sam, Z as in zoo, P as in Paul, and then the number 6. So once again, for you all who are not able to see the screen in front of you, and Ashley has been good enough to put that in for y'all. Thank you, Ashley. And Gloria, to answer your question, CEUs are sent to social workers and nurses via a certificate. I'll do that either at the end of today or first thing in the morning. I'll wait for you to complete the evaluations, which I hope everyone can do by 6 o'clock. I actually have shut it off today. If something comes up, and I know things come up, just email me. My email's on the screen, sbarnes, and that's Barnes with an N-E-S, at carepatrol.com. And our other folks who work with us in Florence and Montgomery and Birmingham and Huntsville are listed on the screen too. So if you work in those areas and have a referral, then please reach out to one of us. We'd love to help your friend or client or patient or colleague, family member, whomever it may be. But we're going to do the medical ethics survey today. We've given out the Survey Monkey address. Thank you, Gloria, for your question. And please do, y'all, use the chat room to ask questions. I'd love for this to be, as much interplay as possible between us. It's got to be dull to sit and listen to me talk every Tuesday and Thursday, y'all. So I'd love to answer questions or have any sort of interaction if you'd like that. But let's get started. It's about 6 minutes after the hour, and we have to show that you're here for 50 minutes or that's why we do the evaluation, and that's why we give the password out later, and it's time to get started. I know someone just joined from the phone. If you did, please make note. I'll read it one last time. We use SurveyMonkey as an evaluation tool. The address is https://www.surveymonkey.com/r/uppercase Z as in zoo, M as in Mary, Y, S as in Sam, Z as in zoo, P as in Paul, the number 6. So those of you on the phone, please make, Pam, if you didn't receive a CEU, did you do the evaluation? And if you did, it could have been that the email entered was incorrect, but please just email me at sbarnes@CarePatrol and let me know which course it was, and I'll send it right on out. And that's true for any of y'all. Now, those of you who are nurses, I have to post those to the ABN website, and I'm going to be doing that here over the weekend. So finally got my apparatus to do it with, and I'm just going to do it over the weekend and knock it out. But thank y'all for being here. Let's proceed with medical ethics. So we've got objectives. That's part of the board's ask of us, is that we teach objectives. And that's one of the things I ask of you in the evaluation, is to assess and make sure that we did cover the objectives. And if we haven't, we need to know that, and so we can do better the next time. Our first objective today, discussing medical ethics, is to learn the 4 pillars of medical ethics. And these are the tools that we're going to use as we talk about the 2 cases that we'll address, that we're going to address here momentarily. We'll use these 4 pillars as a means to sort of parse through that. Now, as I said in the beginning today, our topics were given to us by other folks who participated in former CEUs. So one is, our objective is to discuss the medical necessity of male circumcision in the U.S. And objective 3 is discuss the benefits of breastfeeding by incarcerated mothers. Or it's not so much discuss each of these, but debate really whether these ought to be or not be, whether we ought to make these allowances or not. Now, we're doing ethics all month. We just did cultural diversity last. And so I want to, be mindful of that as we go through these topics. And I have to say, both of them may be a little cringeworthy. Certainly objective 2 could be for some of you, as it is for me. But I do want to honor people who throw out unique ideas. And I think it's a pretty interesting ethical debate. Let's get into it. So let's talk about the 4 pillars of medical ethics. The first of which is beneficence. Now, you all as clinicians know these, I'm sure. Let's review them today, however. Beneficence, as you know, is simply put doing good. Doing good is beneficence. And as you know, as a medical practitioner, you have a moral duty to promote the best course of action in the best interest of the patient at all times. This is beneficence. And the way that is suggested that you understand, whether something meets the criteria of beneficence as a beneficent action or not, would be to ask yourself a series of questions, beginning with, will this resolve the patient's issue? Now, if ever there's a no to any of the questions we're asking in this series.
Okay. I found this on the web. First, the questions beginning with, will this resolve patient's issue?
I don't know why Siri's talking to us. Forgive me for that, y'all. So if the answer is no, then stop. But if the answer is yes, if this option will resolve the patient's medical problem, is it proportionate to the scale of the problem? Okay, is it proportionate? Yes, it will cure this issue, but is it proportionate? And is it compatible with the patient's individual circumstances? Okay, so is the answer yes to the proportionate? This is a proportionate response. And if so, is it answer yes to this option is compatible with the patient's circumstance? Okay, and is this in line with the patient's expectations? So that seems kind of abstract to me. So let's break it down a little bit. So in the case of beneficence, let's say that you are in the emergency room and in comes a teenage boy who's had a horrific accident on a four-wheeler. And so bones broken, protruding from the skin, lots of blood loss. He's in shock. And so, immediately the surgeon comes in and suggests amputation as a possible fix to the issue. And, so the answer is, will this option resolve the patient's medical problem? Well, it will. And then as you get to, is it proportionate to the scale of the medical problem? Then we're in a little bit of a gray area, because the person, the young man, has significant damage. So whatever, if nothing's done, that is he's surely going to die. And if we do the wrong thing, he could have very serious complications either now or in the future. And so is amputation proportionate to this situation? Well, I don't know. So let's say that it's an undecided, but then we say, is it compatible with the patient's individual circumstances and in line with the patient's expectations? And then we have to come to a resounding no. I think anyone would say that if you have a young teenage, a kid, and they had this accident, well, then amputation, while it may fix the problem and may even be proportionate to the problem, it's really not compatible. This would mean that this young person now for 60, 70, 80 years will have a mobility issue and have perhaps other issues down the road, future surgeries, other things, infections possible. In addition, there's probably some mental health deficit of being an amputee at such a young age and not being able to do things that maybe you once wanted or thought you would do, to have that sort of grieving period. So that, I guess that's what we're getting at, is a way to look at beneficence is does it meet all of these criteria or not? And then when we think about it, even if beneficence, all of those issues answer yes, we think this is good, we think we're doing good here, we have to balance that. The same coin of beneficence is non-maleficence, okay, which just means doing no harm. So whereas beneficence means doing good, maleficence or non-maleficence means doing no harm. And you have as much of an ethical duty as a clinician, as a medical practitioner, to do no harm, nor to allow harm to be caused to a patient by neglect. So there's beneficence and non-maleficence. So we cannot do harm. So back to the hypothetical of the teenager with the possible amputation, we would not do harm. Doing harm would be amputating in this case, in that scenario. So that's where non-maleficence would catch us. In fact, any consideration of beneficence is going to really have non-maleficence as a counterbalance or a counterweight. We're going to have to consider both at the same time. For one thing, non-maleficence acts as a sort of threshold, if you will, for whether or not and how we treat. And if the treatment, in this case, an amputation, would cause more harm than good, then we would not consider it. So even if we felt that amputation were in line with all of the beneficent ideas, questions that we asked, we could not verify or justify that it was not a bad thing in the non-maleficence principle. And secondly, and this is maybe more important, beneficence is sort of a reactionary principle. So someone presents to us and we look to do good for them. But with anyone, it's sort of a truism in life is that we're always looking for non-maleficence. We're always looking to do no harm, or most of us are. Certainly those of us in the medical profession are in it to do good and do no harm. And so non-maleficence is as much a part of your life as is beneficence, especially when you're looking at the pillars of medical ethics. The other pillar of medical ethics, and this is one which we'll address a little bit later today, is autonomy. Excuse me. And that's just really giving the patient the freedom of choice in terms of what sort of treatment is enacted on their behalf. And of course, this would only apply to someone who could give consent. We talked about consent when we talked about dementia in the ER several weeks ago. And we talked about, how to assess whether someone has the cognitive function to be able to make the decision and retain information and understand cause and effect and make a decision. And if they can't make a decision, if they're not autonomous, then we need to find a proxy. But if they are, and one of the ways that we determine whether or not they are autonomous is to ask, again, a series of questions. And ask ourselves, have we fully explained to this patient their condition? And have we fully covered all of the options that we see or foresee as possible treatment? And have we talked with them about the advantages of each of those possible treatments and the disadvantages of each of those possible treatments? And has the patient understood this information? And can the patient retain this information? And can the person use this information in the abstract way that a thinking adult can and come to a decision? And if they cannot, then we need to find, again, a proxy. And then if the patient meets those criteria, we've explained the treatment options, they've retained it, they've come to a decision, then we ask ourselves the thing we ask ourselves in every encounter, which is, has the patient provided informed consent? Okay, and so informed consent is one of the pillars of medical ethics, because autonomy is one of the pillars of medical ethics. And justice, ensuring fairness. And justice in this case can mean two things. It can mean the legal justice, the justice by which you are all bound as clinicians. But it can also mean sort of the more esoteric justice, as in moral justice. And maybe a way to look at that sort of justice would be at the end of most every pharmaceutical ad, there's always a disclaimer that says, if you cannot afford this medication, we may be able to help. And so that, in the sense of what we're saying here in terms of justice and medical ethics, that's the kind of justice that we're talking about, which is really the justice of access to healthcare. access to healthcare is what we're considering here, justice. And here is just a summation of the principles of medical ethics. We're respecting autonomy, right? The ability to make a decision and then give informed consent. Beneficence, which is doing good, which is the counterbalance or counterweight to non-maleficence, which is doing no harm. Non-maleficence we practice daily in every encounter. Beneficence comes to us when something presents. It's a reactionary principle in many ways. And then justice, we've just covered legal and distributive or access to healthcare justice. And what I thought was funny was this little cartoon. If y'all are on the phone, you can't see it, but there's obviously the specter of death at this person's desk with the, the Sith and the hood and the blackness beneath the hood. And it's a doctor, I believe, who stands up and says, "Hey, my advance directive was for you not to show up." And I think that's all of our advance directives. None of us expect or want or look forward to that day. So we all prepare as best we can to move forward. All right, so let's go into objective 2. So we're going to discuss, and those of you who are just maybe new, since I mentioned this before, our topics for discussion today were given to us by some of our former participants. And so I'm asking you, if when you do the evaluation, which is necessary, which is password protected, you'll get the password at 12:45 or 12:50. When you do it, please do mention topics of interest to you, because we will do them. And this is one of them. This is the medical ethics of non-therapeutic circumcision. And we're going to look at this from the 4 pillars, the prospect of the 4 pillars of medical ethics that we've just discussed: beneficence, non-maleficence, autonomy, and justice. And I'm sorry, let's get one. So, let's just all understand and agree that when you non-therapeutic circumcision of males, it removes a substantial amount of healthy functional tissue from what we know to be a physically sensitive part of the body, but also it's symbolically, as we all know, sort of an identity for many people. And so this is not trivial. Removing healthy tissue from anyone, from any part of anyone's body, should be scrutinized. And so we'll scrutinize that today. Sorry, I'm trying to move things around on my desktop. So doctors in the US, as opposed to virtually, well, really any other country, are often asked to do medically unnecessary circumcisions on minor male children. And often asked is probably an understatement. I think seems like it's every child. So 50% of children born are having tissue removed from them. And what we sort of have to parse through today is, this is a young person that didn't consent to this, what is essentially an elective surgery. And there's no disease state. There's no, there's no really special ethical rule to apply. So we have to sort of get through that today together, I think. And as people, really, this is really a decision for us as parents when we have children. But for the purpose of today's discussion, we're going to get through this, and let's keep in mind, in the back of our minds, that the person we're talking about here, the patient, which is who we as medical personnel are supposed to be most concerned with. The patient here is the infant child. So the patient is the infant child, and we need to keep that in mind. So the Royal Dutch Medical Association says that there's no convincing evidence that circumcision is useful or necessary in terms of prevention or hygiene. And that's partly in light of circumstances that can arise it's not justifiable except on medical and therapeutic grounds. And so this is the Royal Dutch Medical Association stating that unless circumcision is for the 0.5% of boys who will require one for some foreskin related issue, that it should not be done, that there is no medical reason to do circumcision of boys. And they go on to state, insofar as there might be or are medical benefits, such as a possibly reduced risk of HIV, it is reasonable to put off circumcision until the age at which such risk is relevant, and the boy himself can decide about the intervention or can opt for alternatives. So this is the Royal Dutch Medical Association. And we have to, I think, agree. In fact, we led with stating that respect for human rights is an integral part of medical ethics, autonomy. Children have, I think we would all agree, have not just a general human right, but children have a special human right by virtue of being children. Okay, by virtue of what they represent, the change in the world that they might represent, they have a special human right to not have that interrupted through harm or injury. And so we accept those two things. The non-therapeutic circumcision of young males, of children of either gender, is a gross violation of their rights, including the right to physical integrity. Think about that. The right to physical integrity. And of course, it defends the right of freedom of thought and religion and protection from physical and mental violence. And it may, in some cases with boys, even violate their right to life. Through complications with circumcision, they may lose their life. And parents have the same right as we or you as medical professionals to respect human right. And so when you then think about that child, how do you approach this from an ethical point of view? If we're looking at this from the point of view of medical ethics, if we look at beneficence as relates to non-therapeutic circumcision of male children, there is no medical benefit. And so we don't meet the criteria of doing good. We're not necessarily doing good. And the Canadian Pediatric Society says that any benefits that might ensue from removing the foreskin in infancy are counterbalanced by risk and harms. Again, we're not doing good. And they go on to say that removing the foreskin of the penis may very well confer certain health benefits in much the same way that removing healthy tissue from any other part of the body could be expected to reduce the risk of medical problems. For example, routinely removing a testicle from every male child would almost certainly reduce testicular disease risk. But the cost, harms, and other disadvantages would have to be factored into the equation. And we all know that we've arrived at the answer that this is not what we're going to do as concerns testicular cancer. And in the case of circumcision, then, it's not that there are certain health benefits that may come from it, but whether in terms of a beneficence principle, might we find a less invasive alternative means of achieving the same desired health outcome? Now, the problem is this is subjective in nature, and so maybe harder to arrive at and harder to quantify. And so, the conventional view, whether we're looking at a legal view or a bioethical view, that unnecessary surgery, such as the removal of functional tissue from a body without consent, would be harmful. If you were one of the sort of stories that you hear about someone who woke up in a hotel room with a scar because they'd been drugged and they'd had their kidney removed, Well, we find that abhorrent. My goodness, that's awful. But how is that any different, do you suppose, than having, tissue removed from a male infant? Isn't that intrinsically harmful? And it inflicts harm on the child, who is the patient, and it violates moral rights to physical integrity, bodily integrity. This is a new concept to me, and it may be to you, but it's very interesting, the idea of having an ethic or a right to physical integrity. And given, we protect women from this, as you may know, you may have seen in your past stories of various indigenous cultures from different continents, or maybe those that are fundamental sort of patriarchal religious culture might do body modification or remove the clitoris of women in certain areas of the world. And we find this distasteful. And so I ask you, how is this any different for something that we find to be so clearly and obviously routine and matter of fact in the US? It's a needless injury, and we do protect women, as I just said. And so we're violating right now the principle of justice, the medical ethic of justice. We're not providing the same non-maleficence or beneficence to male children as we are to female children. And it's not treatment. And in the end, remember, this is an elective surgery. And if we're going to have an elective surgery, then shouldn't we have the child making the election? And as an infant, we know clearly the child has no ability to make an informed decision about his body, but doesn't he have the right when he comes of age to make that decision? It should be a violation of the principle of autonomy that we don't allow the infant child to make this decision. And so I think we've covered fairly well the fact that, I'll go back, that non-therapeutic circumcision of male children at birth doesn't really meet any of the criteria of the pillars, the 4 pillars of medical ethics. It is not doing good. It is not beneficence. It does harm. Therefore, it violates the principle of non-maleficence. It is not an elective surgery that's performed equally on both genders at birth. So there is no justice principle at work here. It fails that principle of medical ethics. And lastly, it fails the principle of autonomy. We're not allowing the child to make the decision. I'd love to see some feedback from you. I know this is a cringy sort of subject, but I think we've proven now that this is not the proper thing to do. But what do we do next? And so, Karen, thank you for throwing me the question. What is the age of decision? Do you think the same standards apply to a mother wanting to pierce her baby girl's ears? Not really removing tissue, but it definitely hurts. Some religions believe piercings are wrong, and so should the child be old enough to decide for herself? Well, in terms of ear piercings, I'm really not clear. And it's true that now that you pointed out, Karen, that it seems to be something that's sort of culturally true for different cultures to have pierced ears on an infant. And I don't think that's an ethnic culture. I know, I have family who had children who, it's more of I don't know what kind of culture it is, but maybe it's an Alabama culture. But nonetheless, it is painful. It's not the removal of tissue. I don't think it equates. I don't think it's apples and apples by any stretch, maybe apples and grapes. But I do think, in my own opinion, which is just my own personal opinion, it's not based on any ethical consideration. I mean, I do think a young woman or man should be able to make that choice. And our friends who are Jewish would suggest that that age is 12, which is the age at which young men are bar mitzvahed and young women are bat mitzvahed, which means they're brought into the adult world. And I think 12, particularly given how much exposure children have today to knowledge through their phones and access to information, I think 12 would be an appropriate age. Or maybe maybe you just say maybe not an age so much as at the onset of puberty. So when that becomes a something of which it would, I don't know. It's a good question. Anybody else have an idea? But Carrie, thank you for that question. And to answer it, I think at the age is 12. If you pick a number, I really think the age is based on someone's hitting puberty, someone having a thought about that. And trust me, young men at the age of puberty have a lot of thought about that. And I'll just tell you, so we did this with my son. We did not have him circumcised at birth. We let him choose. And he was 15, I think. And, there were many reasons that he made the decision that he made, but it was his decision. And Wendy, you say that the circumcision it's hard pressed to call that causing harm. It causes pain, just like ear piercing. Harm. Well, I see your point. I mean, I do think it's hard to debate that the removal of tissue is not causing harm if it's non-disease tissue. But maybe it's not. Let's stick with ear piercing, like you said. I guess if you get gauges in your ears, there's some removal of tissue, or is it stretching of tissue? But again, I don't think you would have a child, an infant, getting gauges in their ears or doing any sort of body modification. We don't allow children to have tattoos, and so I don't know. It's an interesting question, but I do think that boys may have the right to ask it or have the autonomy to make the decision for themselves. And certainly that was our decision. And I'm not saying that's, if you didn't make the same decision, that you're in the wrong. I'm not saying that at all. I'm just saying it's worthy of introspection. And Kamala says ear piercing is reversible. Once a child reaches a decision-making age, they may or may not want the piercing and let the ear piercing close. That's great. In Alabama, the legal age to consent, according to Wendy, thank you, Wendy, is 14. The only thing a minor can't consent is the COVID vaccine. Now, how boneheaded is that, y'all? That's nuts. Here's my soapbox. I think that the phone ought to have an age of consent, and I don't think kids should have smartphones. I really don't. I think they do so much damage to kids that it ought to be the legal age. It ought to be 14 before you can have a smartphone, and really, which is probably the worst time when kids are being bullied. But nonetheless, the age of consent is an interesting topic in and of itself. We may do that. Thank you for that, Wendy. I like that idea. So let's go to our next objective, our last objective, objective 3. And we're going to discuss whether or not we feel that breastfeeding ought to be allowed by incarcerated women. And this is a fairly hot topic if you get into the literature. So this is not something that sort of is left field as you may think. It's really and so if you think about it this way, about almost 4% of the women who enter prison are pregnant at the time that they enter. And y'all know prison is for a felony, jail is for a misdemeanor. Prison is federal and it's 1 year or more. Jail is state or county or even city, and it's 1 year or less. And so women who are entering prison are going to have a baby in prison. So, I don't know what number, and I should have known this, what number of women enter prison annually. But maybe somebody can Google it for us. But to think that, 3.5%, 4% of them are having babies in prison, I mean, that's got to be a pretty substantial number. There's only 9 states in the US that have any sort of accommodations to allow for women to, A, be pregnant in a special, sort of wing, and then B, have children, have a nursery, so to speak, and then have some relationship with the child. And I've listed the states here, but you won't find one of those states being Alabama, will you? I mean, most of us are from Alabama on this call. We know Alabama's not in those states. I mean, heck, we're right now, we're still involved in a federal lawsuit about overcrowding in Alabama prisons. It's pretty dire, Alabama prisons are. And so we just think about the women, and I know there are women in this audience perhaps who work in the prison population. And I mean, I'm sure they have 2 million women annually. Thank you, Sarah. So what, 3% of 2 million is what, 60,000? That's a lot of women. That's a lot of babies. Think about it. 60,000 babies born in prison every year. Gracious. And so what happens to those babies when they're born in Alabama? My assumption is, and someone can correct me who's on the call if they know better, but my assumption is the baby is whisked away and placed in foster care, and the mother probably doesn't see the baby very much. I don't know that that's true, but regardless, I think it's very definitely true that there's no ability for the woman in Alabama who has a baby to breastfeed her child. And this is a problem because we know that breastfeeding has well-established physical and psychological effects, not only for the newborns, but for the mothers. So I ask you, number one, on the principle of beneficence, are we doing good for newborns and mothers when we separate them and do not allow for breastfeeding to occur? We know it enhances long-term bonding, and we know this is particularly important to women imprisoned, right? Because they're going to be separated from the child. Oh, thank you, Diane. Diane tells us that if there's a viable family resource, the child will go with that person. But if not, the child will enter foster care. And they do, yeah, Sarah, you were correct according to Diane. So thank y'all for talking today. I appreciate it. It keeps me going. It keeps me energized when y'all introduce ideas. So we know that in order to breastfeed, you have to do it often. So you have to express milk or actually breastfeed pretty consistently, or the milk will stop flowing. And so prison naturally is a problem. I mean, they're just constraints by and because of the fact that it is a prison. So, movement is restricted, access is restricted, physical space is not protected. And so what we see is the National Commission on Correctional Health Care supports and recommends making accommodations for nursing women that will enable them to maintain their breast supply. And Pam asked, can they not use a pump and therefore the baby would not have to be in prison with the mother? Well, yeah, in the states that we're talking about, a lot of the times it's not physically possible for the baby to always be with the mother. So many times they'll express milk and refrigerate it, and then the baby will get that later. But even in that sense, you have to have the accommodations. You have to have a room. You have to have a pump. You have to clean the pump. You have to have a refrigerator. You have to have some mechanism by which to get the milk to the infant. And this is, I guess, where we're going with this is well, let's pause a minute. We know that the Fair Labor Standards Act requires employers to provide a reasonable break time and clean private space. This is not a bathroom, okay, but a room, comfortable, clean room for an employee to express breast milk for at least a year after the child is born for a nursing child. And so you can make a pretty broad stretch in argument to say that because many women are employed in prison, that the Fair Labor Standards Act ought to apply. And there are those who would use that act as a means to make this apply. However, well, in addition, the American Academy of Pediatrics and the American College of Obstetrics and Gynecologists recommend exclusive breastfeeding for at least 6 months of life, and then for another 6 months to do so with the introduction of food. And so we have the Fair Labor Standards Act suggesting that we ought to allow 1 year to breastfeed or express breast milk for a child. And then we have the pediatrics suggesting that it ought to be at least 6 months, but it really 12 months of breastfeeding through breast milk. And so that's what we see in those cases. We see again that we can make a stretch and an argument for having breastfeeding or reasons to breastfeed in prison. And so just one more thought on beneficence is the Agency for Healthcare Research and Quality conducted an analysis of scientific literature, and it concluded that breastfed infants as compared to non-breastfed children rather, have fewer incidents of respiratory tract infections, ear infections, GI infections, sudden infant death syndrome, infant mortality, allergic diseases, celiac, obesity, diabetes, leukemia, and lymphoma. So again, are we meeting the criteria of non-maleficence if we're not allowing the child to breastfeed? So we're not allowing this. We're allowing harm. That is breaking the principle of non-maleficence. And then, so for the mothers, again, in terms of beneficence, we know that they have improved health outcomes when they're breastfeeding, with less blood loss postpartum, less depression. And this is very important, again, for an incarcerated mother to remove the likelihood of depression. Okay. And I think there are women who would appreciate that it also provides for greater weight loss postpartum. And then the other thing is breastfeeding is protective later in life for mothers against later developing things like ovarian cancer or cardiovascular disease or diabetes. So again, we're breaking the principle of non-maleficence by not making accommodations, because this is allowing harm, right? Allowing harm by not providing accommodations for mothers to breastfeed. And so, and here's the other thing, whether they breastfeed or not, we're going to have to make probably some medical accommodation for women due to issues that may come from not breastfeeding, like breast engorgement or milk ducts or mastitis. So these are all things that would be harmful to the mother and also would cause us to have to do something anyway. We're going to have to make some accommodation. Why not make the accommodation that makes the most sense? There are few, almost no contraindications in breastfeeding. Even women who would be, say, entering prison and giving up a life of opioids, which they may have been on when they were impregnated. But even if in prison, they would be on methadone. And this is safe for a breastfeeding mother. This doesn't transfer to the child. And it's also safe for a woman with hepatitis C. So we see that from drug users and abusers in prison. And so this is a way to give that mother who might be a drug abuser or recovering drug addict, maybe, some less cause for depression and more cause for the sense of bonding that she will have with the child and the positive impact that that will have on her life as well as that child's life. And so here are the things that that the literature suggests that we do in Alabama to enable women to express breast milk or breastfeed directly their children. One, of course, we would be screening women, which we would do anyway. We would know women who were expecting upon entering prison, and then we would make accommodations for them at that point, particularly beginning with counseling them on the health of the baby through prenatal vitamins and other things. We would probably, if we could, if it were in the budget, I'm sure we would want to provide a special diet for them as nursing or soon to be nursing mothers. And we would allow them to breastfeed immediately and have lactation support just as we do in the hospital when children are born. And this ought to be the same human right that we guarantee to incarcerated women, no matter the reason they're incarcerated, and most are incarcerated for drug issues. We want to support some sort of visitation that allows the infant, who, according to Diane Hunter and others, will be with a family member, we hope, in the interim. But if not a family member, a foster family. But there has to be some visitation set up to allow the mother to breastfeed directly, as well as provide the milk that she's expressed for the child. And then the prison has to make some sort of accommodations, including with all the things I said earlier, beginning with a room, but then all of the things that would be necessary in order to make that work: the pump, the cleaning apparatus, the storage bags, the refrigerator, and developing a system. And a system is everything. I mean, life is about systems, I think. It doesn't matter. I learned this. We did Dave Ramsey, my wife and I, years ago. It was great. And it helped us immensely to control our finances. But what I sort of learned was over time was that I didn't have to do Dave Ramsey's system, just had to do a system. And that's sort of my feeling about a lot of things, colleges and approaches to life, different approaches to the way that we think. Is what matters is that you adopt a system, a plan, a goal. That what matters less is what that is. And it may change those things. The goal may change, but what matters more is that you choose a path and stick to it, and then, change it as needed, but that you go down that road. And so to me, creating the system then is everything in most every activity. And certainly it is the everything in allowing for or making accommodations for women to breastfeed behind bars. And this would include, may include even establishing a nursery program. And by nursery, we mean that in both senses of the word. Nursery as in nursing, and nursery as in the more conventional, place where children live. And then, this is a dream, but if there could be lactation specialists brought in to Alabama prisons, that would be optimal. And this is according to the National Commission on Correctional Health Care from 2018. So this is 4-year-old information. And again, it's still a hot topic. So I'll leave us with this. Don't just act with kindness, y'all. Don't just act with kindness. Think with kindness. And no, Mary, I did not give the CEU word. I'm so glad, Mary, if it weren't for folks like you, I might forget to do it. So I appreciate you making me aware of that. I'm going to type it in while I'm talking, but the code word is justice with a capital J. All of the other letters are lowercase. So justice is the code word. And the address for those of you who came in late or on the phone, the address for the survey is https://www.surveymonkey.com/r/ all uppercase, Z as in zoo, M as in Mary, Y, S as in Sam, Z as in zoo, P as in Paul, 6. So that's our evaluation link. Our justice is our password. So the link is password protected. Please also use it as the code word. It's the number one, question number one. It lets me say to my boards of nursing and social work that you were here for the full time. You were here because you used this password. And then I also want to leave you with the words of Hippocrates, which is, I can't find them, y'all. Oh, cure sometimes, treat often, and comfort always. So cure sometimes, treat often, and comfort always. Thank you all for being here. Nurses, I'll be posting all of these hours over the weekend, but you as well as social workers will receive a certificate from me late today or tomorrow morning, first thing. Please try and complete the evaluation by 6. That way I'm don't spend several days trying to get evaluations to people or certificates to people. And I know things get in the way. And if it does, just let me know. I'll open the present or open it up back for you. But trying to make sure I don't forget people, as y'all can see by looking at these chat rooms, there are plenty of people who I've missed certificates for. So again, if I'm missing a certificate for you, S Barnes with an ES at carepatrol.com. Just let me know. I'll get those to you. If you watched a recorded CEU from our website and you need a recorded CE certificate, let me know, and I'll open up the evaluation if it's not already open, and you can get recorded certificates. And then soon, if I can ever get my my daughter to do so, we'll have all of these will be on YouTube. Many of them are on my website. So again, the evaluation is on SurveyMonkey, and the password is justice, as in legal and distributive justice, access to healthcare, with a capital J, USTICE, justice. So we've ended just a minute early. I appreciate y'all for being here. Thank you so much for listening again and for keeping an audience strong for us. Please invite your friends. And again, anyone who's a social worker, please invite your colleagues to next Tuesday, which is the next time we'll be here, to hear about self-care, which is now necessary for y'all. So thank you so much. Y'all have a great rest of your day and week. And hope the sun shines on you. Now, today is the longest day of the year. And so I hope the sun shines on you every day of the year and that good things come about for all of us.